Okay, so what we're going to go through here for you now is a pretty low fidelity simulation of a patient being brought up from ED or the ward to one of our ICUs into a side room, and we're going to go through the challenges that intubating that patient will bring when they are presumed or confirmed COVID-19. So what's going to happen is Al's going to be our doctor who's just brought the patient up. They're on a non-rebreather mask and they're not looking great. So we're going to take it from there.
Okay, so I'm in a side room, I'm on my own. We've got this patient, it's not looking great, I need some help. So what we've got on the John Farman, and hopefully we'll sort out for downstairs as well, is communication between inside and outside. So I'm going to use my walkie-talkie. Hi, I'm going to need some help with this patient. I think we're going to have to intubate them. What? We're not protected. Have you got the things that we need?
What are we doing?
So we need to intubate the patient.
Yeah.
We need drugs for that.
Yeah.
You need to be protected for yourself.
Yeah, fine. Cool. Let me go and get my stuff. So, guys, so we're going to intubate our patients. So what we've got on both units, we've got intubation packets that have already been made up. So within these packets, you've got things you need for your intubation. You've got a blade, size 7 and size 8 tube, your HEPA filter, end-tidal CO2, a bougie, and some syringes as well. Again, these things may change very, very slightly over the next coming days as we start doing this more and more and more. But most of your basic stuff is all in there. They're found in the cupboard in the GD suite on NCCU. They're found in the transfer room on John Farman. As for everywhere else, we will let you know where they are when we find them out. As well as those, you've also got a small RSI pack with syringes, kind of poised and ready, and then we'll make up some little drug packs that you can literally grab from the fridge as well with propofol 1% and some paralysis agents and things like that. So once we've done that, I obviously need to protect myself before I go into the room, so I need to don my appropriate PPE. So for all patients in critical care that we're querying COVID-19 or confirmed COVID-19, we will wear full PPE. So full PPE is going to be our lovely splash-resistant full-length gown with little thumb holes. This is a two-person job, is donning and doffing. So donning, I'm going to put this over my head, and I'm going to ask my colleague to come and tie me up in a nice little bow at the back. Obviously, before I've done this, I've washed my hands for 20 seconds with soap and water. You'll notice that I'm also doing it outside of my doffing area. So outside of the room, there is a metre by metre area that is sort of like a dirty area. So I'm doing that outside of that. Once I've done that, I'm going to take off my glasses. I'm going to clean with 70% alcohol. I'm going to leave them there to dry. I'm going to pop on my mask that I've been mask fit tested for. Again, now the pandemic store has been opened, the masks have changed for CUH. So please make sure you get mask fit tested. There's going to be more email communications over the next couple of days about when this will happen. This is what I'm wearing today, but I'm obviously mask fit tested for. Make sure you've got a good seal, and that's all tickety boo. You've got a nice strap at the top, strap on the neck, make sure it's nice and tight, lovely jubbly. I'm going to put my glasses back on. And then I'm going to put on my, Ali's got a nice visor on, we've also got goggles as well, and again, we're finding from procurement what we're getting with regards to these, whether they are disposable, not disposable, cleaning, reusing, we'll let you know. So that's going to go on there, and I'm going to put my gloves on as well, nice tight fitting or well fitting gloves. It's going to go over my hands, over my gown. I'm going to do that for both sides. And the reason we've got two people within checking is to make sure that everything's all tickety-boo, nice and tight. I've got everything on, I'm ready to go in. Beautiful. So, let me take all of my equipment in. Once I'm in the room, so I've got everything there for you. This is going to basically be my skin for the room. This is not going to come off. I'm also then going to put on a pinny as I would do normally for any normal procedures. Try not to knock off my goggles at the same time. And also I'm going to start double gloving as well. So I'm going to put another pair of gloves over the top of the gloves that I've already got on. Lovely.
Okay, so we've got our stuff, standing like that, so we've got all the things we need for standard intubation. So we're thinking here, we're modelling somebody coming with a hospital respiratory failure, so we just need to intubate them for respiratory support. So we're just going to do standard intubation, something we've done hundreds of times, so it's going to be very, very similar to everything we've done before. There isn't much different here. We'll walk through just so you're comfortable. There's a couple of particular things that we'll highlight along the way that are slightly different. So, at the moment we've got our patient on a mask. That's a non-aerosol generating procedure for the purposes of this. We're then going to proceed towards intubation. So we'll need a face mask, standard face mask, same as yours use. The next thing we've got here is the HEPA filter. So this protects you, filters out, 99,000 out of 100,000 particles. So this is protecting you, and it goes on. I'll take this mask off. It's going to be on the patient there. Underneath this, we're going to have high flow oxygen going through the standard nasal cannula, so 15 litres through standard nasal cannula, just to provide some sort of passive oxygenation without us doing anything. We've got our mask, we've got our filter. Next thing we move to, this is where things get slightly different to normal, is our water circuit, which we use to do manual ventilation. But instead of using the angle piece that comes in the pack, we're going to use this extension piece. And the reason for that is because it attaches onto the filter here. So we do that, join these together, and what you'll notice is that any gas that comes out of the patient is going to come through this filter, and therefore if you happen to bang through this, then exhaust gases will be filtered, so you're protected. You've got your PPE, you've got your filter, so you're protected. So that's us, that's our standard setup. There's some other differences we'll come to in a moment. So that's us, if we could give our drugs. Okay. So standard, we're not going to bag the patient, assuming that there's no other complicating factors. We're going to do our best not to manually ventilate. It's not an absolute. It may be times that we try and get a really good seal and do a little bit of bagging to get us through the stage of a really hypoxic. But standard is we'll try not to bag the patients.
All the drugs have been given?
So drugs are in.
Yeah.
We'll have a look. It's tricky, I can't see much. I can't get it in. Can we get an eye gel in, please?
Yeah. Can someone pass me an eye gel into Sergeant 14, please?
Anyone?
You've got a tray that I can not touch me. There we go. Eye gel for you.
Fantastic, thank you very much. So we've got that. I was just going to have another quick look before we get there. Let's just see if magically I can get that now. Have a look, thank you. I'll put that through, that's fantastic. And this is the next point of difference. So we're going to inflate that without doing anything else. So we've got a really tight seal, we've got 5 or 10 mils of air in there. So we're sealed now around this airway. So then, we're attaching here.
Yeah, so all the kits have got inline suction in. So if my ventilator isn't ready, or whatever for whatever reason, or your patient has come up from ED and they've already got their HEPA filter already all kind of sort of attached, and this is to the oxylog, there is suction tubing already in your ventilation, in your intubation packs. So the idea is that we can kind of put this on automatically, so any disconnections we'll be making will hopefully be away from the filter itself. Obviously you've got a port on here as well that you can attach your end-tidal CO2, so hopefully when Al is trying to work out if the tube is in the right place, or hopefully we've got our capnography and we can see the chest rise and fall.
So at this point, I've got my tube in, I've watched it go through the cords in the end, we've got our capnography, the chest rising and falling, the oxygenation seems to be okay. Do we need to listen to the chest, do we think? The tube placement. There's knobs, there's some shaking. So I think the feeling is that we wouldn't routinely. So it's not to say that you can't and you must not, but if the intubation was straightforward, we've got good capnography, the oxygenation stabilised, there's no question mark about chest movement, the tube seems to be at an appropriate length, so there's no need to expose yourself to leaning forward, listening over the chest, putting yourself into a space that might be, at that particular moment, slightly higher risk. It's not to say you can't do it, but it's just making that decision. Do I need to put myself in that position? It's like, do I need to come in the room at all? You know, it's that decision-making process. So that's great, we're all joined up here. We'll just talk about this again. This obviously links to the outside here, normally attached to suction. If you happen to have this disconnected because you're doing mouth suction or something like that, just be aware that if you were to have this unclipped, and that were to get pressed, and this were to be open, then you are at risk of having unfiltered gas coming out here. It's extremely unlikely because you've got 2 layers of protection there, and even if it did, you're in PPE. It's just something to be vaguely aware of if you are switching between one suction unit between 2 things. So that's great. So we've got our tube in, we seem to be stabilising, we now need to get ourselves onto the ventilator. The patient needs to not cough at us. So the patients are going to be paralysed for breaks in circuit, transferring into the ventilator. Okay, so we want the patient not to breathe out. So the patient is paralysed, and then we'll move on to our circuit.
So say this patient came from ED and was already intubated, so we've got the HEPA filter close to the patient and we've got the oxylog on here. What I'm going to do is prepare our filter for our dry circuit. So for all patients that come to critical care that are going to be query or confirmed coronavirus, we're going to have this set up on the dry circuit of an adapter. So this adapter is found within the water circuit. So please do not throw these away, please keep these. This attaches then onto the aerogen, and then we have the HME. And what we've found, so we're moving from the HEPA filters to the HME. The HME is your heat moisture exchange, but also has a level of protection of the filtration as well. The difference between the two, I think, was what, 1 particle per 100,000, and this is 10 particles per 100,000. I remembered something. Yes. So as Ali said, we're going to make sure that our patient is going to be paralysed. We're going to turn off the oxylog ventilator. I'm going to then disconnect, attach this onto my dry circuit, and then I can start ventilating my patient on my servo eye. It is also worth noting, so obviously on our circuit itself, we've got our inspiratory port, but on the expiratory port, we still have our yellow filter that we would normally use as well. So you've got a second layer of protection as well on that part.
So I guess the key thing to say there is that this looks very similar to every other intubation scenario that you've ever done in your clinical practice. 2 or 3 bits that are slightly different, and they might take slightly longer, but that's okay. If it takes you another 10 or 15 seconds just to put the green bit on here or it falls off, then don't worry, it's fine. That's not going to make the difference. Put it together slowly, put it on, and it'll be fine. Okay, that's just the process that there is. These are the things that we need to get in the circuit, both to protect the staff, because we need everyone to be well and feel protected and feel like we're going through the right processes, but also it's not going to do the patient genuine harm.
Cool. So I'm now ready to leave the room. So with any aerosol generating procedure, we want the door to be ideally closed for at least 20 minutes. So we find by the time you've drawn up all your propofol, your fentanyl, you put the anchor fast on, you put an NG tube, and you put a central line in, it's probably been about 20 minutes anyway. To do this, I'm going to remove my outer layer of PPE first, as I would do before. So they're going to go in the bin, and I'm getting bored of the white one now, so I'm just going to break it. That's going to go in the bin as well. And then this is what I need to do, my proper doffing of my PPE. So the majority of my PPE will come off within the room. So to do this, obviously my hands are dirty at the moment. So with my dominant hand going to the outer part of my gloves, obviously the dirty to dirty, that's going to come off. My hand is now fairly clean, I'd like to think. That's going to go underneath my glove and pull that one and go straight into the bin. In between each step, I'm going to alcohol gel my hands and make sure that they are clean as well, just reducing the risk of contamination. The second part is I'm going to... Can someone just quickly untie me at the back?
Yeah.
Sorry. Just because, so ordinarily, what I would do is then rip the top and rip the back and then pull it forward, touching the inside of the gown as much as possible. I'm not going to do that because I still need to use it. Touching the inside, pulling it off, straight into the bin, and then washing my hands in between as well. And then, ordinarily, we would try and throw away the visor and that would go in the bin. However, I realise there's been an issue with sort of where we're getting these from, so with this we may keep these on until we leave outside and then clean them on the outside with Clinell and Claw Clean and whatnot. So now touching my visor, I'm going to clean my hands once more and I'm now ready to leave the room. Once I've left the room and I've touched the door, I'm going to gel my hands again because I've just touched the door handle. And before I do this, I've still got my glasses on, so my glasses are going to come off. I'm going to wipe them with the alcohol gel. Just touch my dirty glasses, so I'm going to alcohol gel my hands again. And once I've done that, I'm now ready to take off my FFP3 mask. So from the back, finding wherever the strap's gone, I'm going to take this off in one nice swift movement, straight into the bin. Alcohol gel my hands again. I'm now ready to leave my doffing area. I can then go to the nearest sink, wash my hands with soap and water for 20 seconds, then go and change my scrubs. I'm escaping. Any questions at all, guys?